Hi, my name is Paulo Almeida. I'm a trainee of anesthesiology at Bragas Hospital, Portugal. In this presentation, we talk about teamwork in ambulatory laparoscopic abdominal hernia repair with mesh reinforcement. Abdominal wall hernia repair is one of the most performed procedures by general surgery. The use of mesh reinforcement is associated with significant decrease in rate of recurrence when compared with suture repair. However, the use of tacker fixation is associated with significantly increased postoperative pain, difficult to manage in the ambulatory care setting. Our anesthesiology department, in straight cooperation with surgery department, developed a protocol that aims to improve the ambulatory laparoscopic approach in these patients. This protocol includes a multimodal and preemptive analgesia regimen implemented by the anesthesiologist with a tap block guided by laparoscopic visualization performed by the surgeon before mesh insertion. To be included in this protocol, patients must have admission criteria for ambulatory surgery, and the specific criteria are umbilical and epigastric hernia, incisional hernia, spigal hernias, multiple hernias regardless of the size, hernias associated with pathology subject to simultaneous treatment by laparoscopy, and the use of intraperitoneal onlay mesh. The exclusion criteria are age below 18 years old, patients on chronic medication with opioid or with a history of chronic painful syndrome, patient with renal or liver dysfunction, and history of allergy or contraindication to drugs proposed in this protocol. The surgery must be scheduled uh, for the second operative time in the morning, and they have to stay overnight after surgery. The admission patient must be admitted at and prepared 2 hours before anesthetic induction, and gabapentin and thromboembolic prophylaxis must be performed. Before anesthetic induction, ketorolac, paracetamol, antibiotic prophylaxis, and pantoprazole uh, is given. For monitorization, we use as a standard neuromuscular relaxation and anesthetic death. Anesthetic induction. um for anesthetic induction, we choose propofol, fentanyl, and rocuronium, and the anesthesia is maintained with sevoflurane. After anesthetic induction, dexamethasone, ketamine, and lidocaine bolus, followed by an infusion, is administered. Before mesh insertion, a bilateral tap block with ropivacaine and dexamethasone is performed by surgeon guided by laparoscopic visualization. Before surgical closure, tramadol and ondansetron is given. In the recovery area, the analgesia protocol includes paracetamol, ibuprofen, gabapentin, tramadol, ondansetron, and for rescue analgesia, we choose morphine. Note: if oral diet is not established yet, medication may be administered endovenously. Patient is assessed for pain, sedation level, and the adverse effects of medication in this periodicity of time. After a 24-hour stay, we give patient discharge if he meets its criteria. Phone calls for assessing pain, sedation level, and adverse effects is effectuated after discharge in these days. Uh, the analgesia protocol after discharge is paracetamol, ibuprofen, gabapentin, tramadol, ondansetron, pantoprazole, and for rescue analgesia, we maintain morphine. This is the treatment guide we give our patients after discharge, with the medications, dose, and periodicity. The protocol has been successfully applied to two patients at this moment. Both patients had adequate acute pain control at hospital discharge day 7 and day 30. Rescue analgesia was not needed. Therefore, both the anesthesiologist and surgeon play a key role in promoting adequate pain management and, better patient satisfaction in more complex procedures in the ambulatory setting. Both the cases motivate us to start the prospect randomized trial to prove the efficacy of our protocol. Thank you for your attention.